everyone. This is David Harlow bringing you dispatches from the front. I'm on the exhibit hall floor at HIMSS 2019. I'm speaking with Jorge Miranda, EVP and Chief Revenue Officer at Lightbeam Health Solutions, which is helping physician practices succeed in a risk-based contracting world. Welcome.
Good morning, David. Nice to meet you.
What does your typical customer look like, and what exactly do you bring to the table in terms of your platform that helps them?
Absolutely. Our customers really have one common element, and that is they're all taking on risk. So they're risk-bearing entities of different types. There's health system customers, which is what we're representing here at HIMSS. There are provider-led customers that are physician groups, and then we have payer customers as well. And the common element there is that they all have decided to go into value-based care and to manage a population of patients to reduce cost and improve quality.
What's the special sauce? What are you bringing to the table?
Well, Lightbeam Health took an interesting approach to managing population health, and the platform was built from ground up. So unlike other companies where there was acquisitions being made across 4 or 5 different products, Lightbeam actually was built organically as an end-to-end platform. And what that really means is that we've gone away from interfaces and moved to innovation. So instead of having to worry about connecting the pieces and parts, they all work together. They're all built together to be interoperable. So that generates a lot of speed to value for our customers, and they're able to get off the ground quickly and generate results very, very fast.
So you're drawing data from other tools and services that your customers are using. So there are integrations. What you're suggesting is that we have now just a single layer on top of that?
That's correct. We've integrated data from all kinds of claims, clinical, social determinants of health data sources, and we've built pre-built adapters. We call them as connectors. And that allows us to get off the ground quickly for our customers. So that speed to value I mentioned earlier allows them to move from data aggregation to the insights layer, which is really where the magic happens. The data has to be in place first. Without the data, then the insights aren't going to be rendered properly. So we spend a lot of time on data, making sure that's 100% hardened and accurate, because providers, we've learned, in order for them to engage properly, they have to believe in the data. And that's the number one factor that Lightbeam has been very focused on, is getting physicians engaged in our platform, because once the insights are rendered, then that's where the real magic happens.
Great. So what are the other sources of the data besides the traditional electronic health record?
We pull a lot from social determinants, so social data from the EMRs, social data from outside sources, such as patient-reported data, HRA data, lab data, things of that nature. And then traditionally we've pulled claims data as well, so we can bring together many years of historical claims data. So that normalization into one common holistic patient view allows that data set to start rendering the insights. Without all those different data sets, you'd have one view of the patient, not the holistic view of the patient, which is what we're after in population health. It's what happened to the patient, not just in the network, but outside of the network when they're traveling and so forth.
Right, sure. I mean, that's the question always, sort of what's the provenance of the data, which also always sort of cracks me up, because the patient walks into a doctor's office and the doctor asks you a question and you give an answer, and then when we talk about electronic data, the doctor says, well, I don't trust what the patient says. I don't want to look at patient-reported data. But ultimately, that's what we really need to look at. Do you look at different sources with a different sort of jaundiced eye? Do you filter certain kinds of things? Do you apply any sort of analytics before it goes into the platform and is presented to the clinician?
Yes, as a matter of fact, all the above. So we actually provide a very robust risk model that generates a risk score for the patients, and that risk score tells the physician and the clinicians how much of an impact can they have. We call it the ability to impact, ATI score. It's a proprietary score that Lightbeam generated, and that allows the clinician to focus on the highest cost, highest risk patients where they have the highest probability of moving the needle on quality and cost in the future. So it allows them to really focus their resources on the right patients. That way they're able to move that needle on quality and cost improvement over time. And unlimited resources are not something healthcare has. So you have to really kind of tenor your resources down to what you can really make an impact on for your population. And the insights we generate on the risk scores allows the providers to really hone in on that patient that needs the care the most versus a patient who maybe has pancreatic cancer, who maybe is not going to be able to move the needle on cost, but certainly treat them as best possible. But if you have another group of patients who have, say, multiple chronic conditions, and they're not exercising, they're not eating well, things of that nature, those you can make an impact on quality and cost. And certainly costs can be avoided in the future if you get them in regular conditions, regular intervals of care, and then also engage them in a way that they want to be engaged. So personalized interventions, personalized engagement, things of that nature, are all things that the insights tell the clinicians what is the best way to engage that individual, and what is the best way to draw them back into practice and get them back into the evidence-based guideline.
So you've described what we might call the low-hanging fruit, sort of the things that will get you the most bang for the buck. Sort of within those groups, if you could pick maybe one or two and talk about some specific indicators that are sort of high-value indicators as you look at your risk model?
Absolutely. One of the areas we're looking at is the ability to predict a diabetic patient, for example, before they become diabetic. So there's a lot of patients out there who are taking their medications for diabetes. Maybe they have an A1C test for diabetes, but they're not quite diagnosed yet. So our algorithms, especially our AI algorithms, allow the clinicians to look into the data, find those patients who are trending towards diabetes, as an example, and then head them off, bring them in the office, get them treated before they become diabetic. And we found that actually is a great way to reduce and avoid, actually, future costs from occurring altogether. So that algorithm is something that Lightbeam has designed, and our clients are now using that to prevent future spend altogether.
So this is in the wild then, and so what's the experience been to date? And do you see great successes? Do you see opportunities for further development of different sorts of algorithms, different kinds of patient populations, different parts of the country, different kinds of providers? What does the future hold for you?
The future hold for us is that once you have that predictive analytics built, then really population health management opens up another realm of opportunity. So, for example, one of our customers asked us to work with them to identify COPD patients before they hit the ER. So we're working with them to use the same algorithm, and allows us to look at the data, look at markers, and then before the patient becomes an ER visit enabled, then we can actually reach out to the patient ahead of time proactively and get them in the office. So COPD and ER admission reduction is one area that we're focused on because of the fact that EDs generate a huge amount of spend. There was a premier article that came out this week around 30% of ER visits could be avoidable because they're tied to one of the 5 chronic conditions, COPD being one of those, diabetes and cardiac condition, things like that. So as you become more in with the data, you're able to start creating models that helps you identify and predict populations that might be heading in the wrong direction, and then start course correcting early. And that's what the analytics and the risk scoring allows us to do in our data set, is take that proactive approach and generate better results for our customers.
Well, great, Jorge. Thank you very much for speaking with me. Sounds like you're trying to move that super tanker of the healthcare system, and we hope that that's a successful endeavor.
Thank you, David. Appreciate the opportunity.
We're back at HIMSS 2019. This is David Harlow on Healthcare Now Radio with Matt Cox, Chief Marketing Officer at Lumeris. Welcome, Matt, and thanks for joining us on Harlow on Healthcare.
Thanks, David. I'm glad to be here.
We're taking a quiet moment out from the HIMSS sanity, as they say, and talking about some new work in healthcare. Matt, this year, like every year for the past 25 years or so by my count, is the year that value-based care is really going to take off, right? Well, naturally, things are a little more complicated than that, and Lumeris has just released a survey noting that less than a quarter of payments for healthcare are made based on value. Tell me a little bit about where we are and where we're going on this journey.
Thanks for bringing up the idea that it's taken 25 years and we're still not fully there. Appreciate it. What a great way to enter. I mean, that part of it actually on some fronts is a little disappointing if you think about it. On the other hand, value-based care is probably poorly defined. There's pay-for-performance initiatives, there's initiatives that have been launched around quality, all of which get traditionally lumped into this idea around value-based care.
Well, it's the proverbial elephant in the blind man, right?
That's right. It's true. I think that what we're really trying to do is bend this cost curve, right? And the opportunity is coming of age because it's going to be driven mostly off the back of there's no more increase in Medicare reimbursement. And for the first time, we're seeing evidence right now where not only is Medicaid operating at a loss for hospitals and health systems and providers, but Medicare is starting to operate at a loss. We used to think Medicare was sort of break even.
Right.
We got to get to value-based care, but when we talk about value-based care, we talk about taking on more risk. So how do providers and health systems take more risk? And that's the part that I think is pretty exciting.
Right, well, they need to do it. And, I mean, people have been doing it on a pilot and demo basis. I mean, I was involved years ago in some of the pre-ACO pilots and academic medical centers trying to get a piece of the action, and they didn't have the data tools available to really manage that. And, the old adage is you can't manage what you don't measure, right? But some of these folks had Excel spreadsheet workarounds to their enterprise IT systems because they couldn't program the stuff that they needed to manage a risk program, sort of, early days of value-based care. So where are we on that evolution? How far have we come? Tell me it's far.
No, it's not.
Okay.
And here's why. When we think about data, we think about it, and I guess you could think about it in two buckets right now. There's a third bucket we can talk about relative to social determinants of health, but the two buckets are claim data and clinical data. And within claim data, you can lump in the PBM data, et cetera, around drugs. That data is really messy. And payers have historically made poor investments in their platforms and poorly managed those platforms so that the data we're looking at that contains cost is woefully inadequate right now today. There's a lot of cleanup that has to occur, and then we have to marry that data with the clinical data in order to be able to make value-based care decisions. So while the tools are getting better, we spend an inordinate amount of our time as a value-based care provider cleaning that claim data that we get from outside sources. The data we get inside of our own system that we produce is relatively clean, but that's because we've been using claim data to manage value-based care. I'm concerned about that claim data and the services and the need to clean it and marry it up with the clinical data. Because clinical data doesn't contain cost, right? You can get a lot of good EMR data, you can get a lot of good clinical data, but until you marry it up with the cost component of it that comes through in the claims, it's really tough to practice value-based care.
Right, and all these different kinds of data are collected for different reasons, right?
Yeah, no,
and so
yeah,
the focus is on different issues as the systems have been built and as the data is collected and recorded and coded and so forth. Although, again, that's an optimistic view that it's being coded in some way and it's not just all free text somewhere. So I know you've been building some tools with Cerner, so I want to understand what you're doing in terms of taking this to the next level.
Sure. So we're pretty excited about our Cerner partnership. It's really rooted in Cerner's open API culture around how they view an agnostic source of data. So that was really important to us. When we looked at our roadmap of where we wanted our next generation of our population health platform to go, one of our prerequisites was we have to have a system that deals with open APIs, that we believe in a world that's transparent, that providers need access to that information wherever and whenever possible. And their open culture, open stance, their participation with Commonwealth Health Alliance to say, hey, we need open standards was really important to us. The other piece that was important is we look at the assets that come alongside of the population health, things that we need to do to monitor and manage high-risk patients like devices, some remote patient monitoring, things we need to do around portal and outreach, things we need to do around customers, right, like a CRM tool, really important to us as well. This consumer coming in is going to want and demand better service, better access, and hopefully through our model and our partnership with Cerner, we can create that. But it's not all about Cerner. We do have Epic customers, we have other customers out in the marketplace, and they want access to that data, and we need to get it into their workflow, and that's what's really driving it.
So that's what you're doing. You're creating a layer that allows this to be surfaced in a way and combined in a way that hasn't been done before, and allows for some decision making and action at the provider or provider administration level.
Yes. So what we want to do is leverage the platform and the technology in order to curate, enrich, transform that data. Where needed, we can serve it up in a population tool that Cerner has. If you're already adopted, if you're an Epic customer or you're a NextGen or Athena, and you want us to push that data inside your workflow so that it surfaces at the point of care when needed, we're going to do that as well. The last thing we want to do is ask somebody to launch something brand new at a time when physician burnout's at an all-time high, and they don't want to click on one more thing, That's just not going to work.
Do they get to click on one less thing?
I'm very pragmatic. I don't want to say that just yet. I would like to think that our ability to aggregate and leverage the data and the APIs means that in order for you to close gaps in care, there should be less clicking of those standards and the areas that got to be met. But I want to take a cautious wait and see.
Well, Matt, here's to fewer clicks and better population health.
Yeah, thank you. Really appreciate that, David. And I enjoyed this talk. Good luck with the rest of the show.
And to you, thank you. Thank you for connecting at HIMSS 2019. Here we are at HIMSS 2019 in Orlando. This is David Harlow on Healthcare Now Radio. And I'm speaking with Arshad Noor, CTO of StrongKey. Arshad, so we all know that cybersecurity is a significant issue that we all need to be concerned about. Can you give us a sense of how significant is the risk and what are some of the key areas of concern?
Sure, David. The problem with cybersecurity, I think, is far more significant than most people recognize or estimate. This is a consequence of the fact that the United States was a leader in deploying computer systems back in the 20th century. And many of the technologies that were deployed to handle critical infrastructure or mission-critical systems, they still continue to be used, but not all of them have been updated to address the threats and vulnerabilities that exist on the internet today. And as a consequence, I've been seeing personally since 2004, breach after breach after breach that just don't seem to be abating. Even some of the most sophisticated companies and the richest companies succumb to vulnerabilities that seem to get away from them. And as a result, I personally believe that American corporations and, of course, companies outside the US too, don't seem to recognize the threat that exists, and their focus is being scattered because there's so much noise in the security industry. It's hard for them to pay attention to what really matters.
So what does really matter?
So what really matters is recognizing what the attackers are after. So attackers have a few very simple objectives. Either they are after desktop computers and laptops, maybe because they are trying to mobilize a zombie army, but that doesn't necessarily breach data. There are different kinds of attackers who primarily want the sensitive data, credit card numbers, PII, healthcare data, because that leads to monetary advantage for them that could then be used for other purposes. Information is valuable to the attackers because there is a very vast underground market for credit card numbers, PII, and PHI. Today, most of these solutions in cybersecurity tend to focus on the network. Not enough attention is paid to actually protecting the information itself, the data itself. Where StrongKey differs from the rest of the industry is we've looked at the problem very carefully, recognized that what the attackers primarily want is the data. So our philosophy is protect the data first, and in a manner so strong that you could have attackers on your network and still not breach any data. How do you do that, you might ask? Very simple. Every application has an entry point. There is typically a login web page, and users have to type in some mechanism to authenticate themselves. The vast majority of systems today, unfortunately, use a 60-year-old technology to authenticate themselves. And what is that? User ID password. I don't use anything in my home that's 60 years old.
Right.
I don't know of anybody else that might be using a 60-year-old technological invention in the 21st century. And it just boggles my mind that we're still stuck using user ID passwords with some of the most valuable information behind that. So we've recognized this problem, and we've been advocating for the use of public key cryptography for the last 20 years, because public key cryptography essentially eliminates all of the secrets that live on a server, and as a consequence, the attacker has nothing to compromise. The protocol used by public key cryptography is radically different from any other authentication scheme that has existed in the past. And more recently, we've been hitching our wagon to the FIDO Alliance protocols.
So tell me about FIDO.
So FIDO Alliance is a nonprofit standards group, and it's a collection of companies from around the world, more than 200 of them. And what they do is they work on defining protocols that are open, royalty-free, accessible to anyone in the world, and anyone may choose to implement them. They implement them either as authenticators, or they implement them in servers or browsers and operating systems. StrongKey implements a FIDO certified server, but companies like Mozilla, Google, Microsoft, Apple, they implement the protocol in their browsers. Google and Microsoft have also implemented FIDO in their operating systems, Android and Windows, for example. And there are hundreds of companies who have built FIDO authenticators, little hardware devices that generate and manage FIDO cryptographic keys. The principle of authentication is very simple. Every website requires a user to register a FIDO key with the website. The protocol is defined in such a way that it can detect and prevent man-in-the-middle phishing attacks. The protocol requires that a human be present in front of the computer that's trying to authenticate to a site, and well-designed authenticators will use cryptographic hardware that are designed to protect the keys in them. As a consequence, a combination of all of these security measures makes FIDO one of the strongest authentication protocols in the world today. Even the National Institute of Standards and Technology, last year they published a special publication, 863-3, which are the digital identity guidelines for the US government. They have given FIDO the highest assurance level of all authentication schemes on the market today. So the industry should be using FIDO to eliminate this single largest vulnerability in applications today.
So how are you using it, and what are you doing in terms of protecting identity, protecting data? What is it that you're adding to the FIDO protocol, and who are your customers who are using this?
So our belief is that in protecting data in systems, you have to take a multi-layered security approach. On the front end, you make sure that you're strongly authenticating users who are trying to authenticate and use the application. And by using FIDO, you eliminate the single largest vulnerability into the front end of the application. On the back end of the application, you use application level encryption to encrypt sensitive data. Whether it's PII, PHI, financial data, it really doesn't matter. Now, why application layer? Because this layer of the technology is at the highest level of the stack. So as a consequence, an authorized application is the only one that can encrypt and decrypt data. Anything below that application layer is only going to see encrypted data. So if you have a vulnerability in the operating system, the database, or some library, the attacker is not going to be able to exploit that vulnerability and access the sensitive data because the malware injected by the attacker is not the application. The last component that we offer in our solution is the ability to digitally sign information, records, and files. Why is this important? Because almost every system that I know today, they make the assumption that data stored in a database is exactly what they should be working with. But they have absolutely no idea that it could have been modified by an attacker. A nurse may give a patient the completely wrong dosage of a medicine if just a tiny vital piece of information is modified in the patient record. The only way to detect that this information is invalid is to introduce a digital signature at the time the data is stored, and then upon reading it back, the application must verify the signature to make sure that the integrity of the data has not changed. Only in that way can a system consider the information to be secure enough to be used for whatever business purpose. So from a solution point of view, what StrongKey has done is it has bundled strong authentication FIDO, application level encryption tokenization capability, digital signatures, all in a single appliance, and backed it up with hardware-based security and key management. Because cryptographic keys are one of the most sensitive aspects of any system. And if those keys are not using special purpose hardware to protect them, then a compromise is almost guaranteed. So you're familiar with the Marriott breach?
Yes.
They were not using hardware-based cryptographic key management. And that's the reason why they got away with all that data.
Okay. Well, working on keeping us safe. Thank you very much.
Doing our best, David. Thank you for spreading the word.
Great. This is David Harlow connecting at HIMSS 2019. You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.